these are the 4 teeth that we're going to remove.
Okay.
Okay. And if you look at this one here, the roots are pretty long and thin. This came in when he was about 6.5 years old.
Okay.
This one came in about 12, and here's the one that we're going to remove.
Okay.
And you see that the roots are not fully developed.
Right.
You can barely see 2 parallel white lines here. This is a nerve.
Okay.
And the roots of the teeth kind of come down close to that.
Okay.
Okay, so there's a possibility of a paresthesia here, but very, very minimal.
Okay.
Because the roots are not formed.
Okay.
This dark area at the bottom of the roots is where the roots are still trying to develop.
Okay.
So if you're going to remove them, this is the time to do it.
That's why I jumped on it.
And surgical, and I covered them with the plastic though.
Yeah. Oh, I hate the plastic though. Ugh. Yeah,
You do? Because it
it's
slides.
hot and it slides, and it's a
slides.
pain. It's a total pain. Let me see if I can find the tooth. Yeah. Oh, this one is really an easy one. The tooth is just sitting there begging. We don't have to remove any bone or anything.
These are my cases.
This is just going to.
That's what I said.
This one's just going to fly out of there, I think.
Like that.
Is it very cut? Right? You got that one?
You can see the tooth yet.
You can see the tooth sitting there. I didn't remove any bone or anything. I see it just sitting there.
They're reflecting in the it's like exposed already.
And it's a little bit. It's not a lot, but it is a little bit to the palatal side. What you're seeing is actually not the tooth there. It's just the tissue over the tooth, the follicle. Okay, so let me see if I can get in here. I'm going to try to remove some of the. Okay, now we can see it really well. So. Get in here, and I'm gonna. If you look at the monitor now, yeah, you're going like I'm kind of rocking here. I'm doing this. See, okay, so I mean it's ready to come out. Okay, so I'm just gonna do this. There's the tooth. Okay, try not to hold back because you're pushing it way back, and then that make it hard for him to breathe.
Okay.
Yeah, just let it sit there like that. It's better. Okay, so let's suction this up, Brent. Yeah, that's good. Whoop. Okay. It's kind of like, I mean, this is, boy, you're not going to ever get any easier than that. You could do that one with local anesthetic so easily.
Wow.
And this is the argument. Like when I was on Dental Town, and I got kind of ripped on Dental Town for doing them early. This is the argument. The GPs that they said, hey, I'm doing them too early. They want to do them like this. And I'd say, yeah, it's great. If you're lucky and it ends up developing like this, but what if you wait? And it's not really like this. When you could have done it when they were like 13, 14, and you have guarantee that there's no roots, right? Because it's not. You're not always going to end up having one develop like this. And there's nothing wrong with doing it like that if you get lucky and it ends up being like this. But there's not even any follicle in here because the tooth is so developed.
Right.
I'm not getting any follicle at all, and I didn't have to touch the bone, so I don't have to do anything. We're just done with that. Let me just push everything back in there. So I'm just making sure that the flap is in place. Just push back. There's nothing sharp there. So there's no sharp edges. If there were, then I go back in there and look at it again, suction it, and again smooth off the sharp edges or remove the loose bone that's on there. And I think this one's the same. Yeah, this should be, instant replay. Really easy one. Now these, I went to UCSF when I was in dental school. When an endo, we had this Dr. Gwen, who was the endodontist, and whenever he had a really easy endo, somebody called me and say, "A monkey could do this one. A monkey could do this." But a monkey could do these. These are really easy. Yeah. These are not difficult at all. I guess you can see pretty good, Brent, on this one, right?
Yeah.
So I'm just, you can also do, this, but you can go laterally, right? You don't have to just go vertically with this thing. I just want to slide it like that to make sure it's clean, so it goes flat. Just stay on the bone. And you can, the same as the other side, you can kind of see the tooth there a little bit.
You're okay with parents watching?
They're out there, yeah, I guess so.
Yeah.
I guess so, yeah.
Yeah.
Okay, I'll let you see. This is the same thing as on the patients from this morning and earlier, so there's nothing new here to see. Okay, I have to take that out for a minute because I need to get the That's the problem. I want to get the camera in there, but I need to have it, see what I'm doing on the corner here?
Yeah.
You can't have the retractor. So I can feel that this is in position. And when they do that, that's a good sign, actually. That means it's coming out. When they respond a little bit. Okay. There it is. And I really don't care that it makes a little bit of noise because he's not going to remember that. By the way, this is when the tooth is coming out like this, especially one like this where it's really easy and it's conical. This is where you have to be careful with it going behind the gauze, right? Make sure there's no openings back there, behind your protection of the foot back. You have a little tiny opening, and sure enough, that tooth's going to pop out and go right down that little opening behind the gauze, and then, oh man, patient starts coughing, and they might actually inhale it. That would be one of those disaster things. So, when the patient swallows and it moves, I always reposition. Everybody make sure and my assistant, I make sure my assistant knows that they should tell me if the retractor moves and I don't see it. Or if there's an opening in the gauze where something could get behind it, even fluids, like liquids, blood or dust. If they see an opening, they tell me, and then I say check the gauze or something, and I'll make sure the gauze is in position. This is why it kind of bugs me about Murph. You just did it fast. And
I think he's really good at it. It's just
really
that,
good at
it. Like I said, we all can.
Dental down stuff? Where is he on the dental down?
Yeah, dental sound. Under the maxillofacial surgery thing, you'll see it's really amazing. I'm totally impressed with him, though, that he's been able to build the following. He has like 140,000
He's been
hits.
there for a while.
Maybe Justin can, he can talk a little bit about how he does it since he's been doing this for a while.
So you don't do the ice pack, just a gauze, basically, right? Gauze and the paper.
So you can see that he kind of like squinched up his eyes a little bit on that because that was the long buckle, which I didn't do before. So that was the first time. But after you do it, he doesn't remember that. So that is the beautiful part about the sedation. And that's a lot of that. And probably most of it is the triazolam, I think.
Right.
So. Wow, I can't believe what a great job you did on scheduling, George. Are you guys doing, Tammy? I mean, man, these patients are so perfect. And actually, if I was going to put them in the right order, this is how I would do it. I mean, you have the easiest one last. It's really nice, yeah. You're getting tired, doing that, because here we can't, I can't necessarily do hands-on because, like, you don't have a California license. Yeah. But if I had, I could do it. If we went down there, so this is one of the things we could do if we form a group. If I could get 20 or 30 people, and we could get some worked out like what he's got, we could all bleed as much as it would if I didn't do it. Yeah, and when it's all bloody and you can't see what you're doing, it's not good. So I'll try to keep it. Okay, let's see here. Is his head in the wrong position? Is that why you moved, Wayne?
Yeah.
Okay, let me. I think it's better where you were. I can reposition him.
Really?
Yeah.
Let me go back?
Yeah, go back to the other place. I think we're not seeing very much there. What I'm going to do is I'm going to move the chair so you can see better with your camera.
What do you think?
This is actually better for me too.
I just do a low one. And then you do the wedge.
Yeah.
Because I don't do the line.
Yeah, there it is, right?
Yeah.
So be careful when you go to the lingual because sometimes I go through and then I put a little vertical thing here and then it doesn't close very well. So sometimes I'll use the blunt side like this. It actually works pretty good. It's just I'm trying to.
But you never lift that lingual side, even just a millimeter?
No. I just, it's probably okay, millimeter too, but why, I don't need it.
Yeah.
You do not need to do it. And the lingual nerve is you don't hear, everybody always thinks about the numb lip, but the tongue is the one that where you get problems.
I have paresthesia on my own.
And you have it now?
Mm-hmm.
Wow.
Yep.
Oh, that's interesting. Okay, so we got to hold the chin here. Okay, hold like this, or with the camera, and then. Okay, I'm gonna. Yeah, good. You can hold it down. Good. Okay, so here we go. Everybody can see what we're doing, right? So I'm just gonna move. I'm just moving the papilla first. We get the papilla going. Yeah. Okay. His tissue. Okay, everybody knows they got different tissue types, right? His tissue is really delicate, so I need to get in this position. So go. over here, and I have to go slowly because this is going to rip or tear. This tissue is very delicate compared to the other ones that we've seen today. Yeah, I just want to make sure we don't have a huge tear in the tissue. Okay, that's good. Trying to get that color up there. You can tell by looking at it, the biotype is different here.
Right.
Yeah.
It's thinner.
Pretty
It's
fragile.
very, very thin. So, I guess if you
The
really...
girl before, she had a very thick biotype.
Yeah.
Very, very thick.
Yeah. I mean, if you have time, maybe this would be a good one to do you could do like use your blade in here, but even though the papillae are kind of like tortured here, I've kind of made a mess of the papilla, they're going to come back. They will for a young person like this. This is, not only is this tissue really thin, it's also very adhered to the bone. So, you got double problem here. These are the kind that do tear or rip. Okay, let me just. I'm going to do this again just so it's kind of tight here. And my retractor. Okay, right here, there's no attach. So. Okay, let me try that. Okay, so we're still trying to get the flap open all the way. If you feel a lot of tension on the flap, you need to do some more something, because the flap should be passive when you put the retractor there. It shouldn't be really adhered on there.
You want the scissors?
No, I think I'm good now. I think I got it with the blade there. I'm just going to make sure, because this is where it usually tears if it's going to, like right up here on the medial. Well, that tissue is really thin. Okay, we're done with that one. So do anybody need to look at this? This is kind of the same thing we've done over and over again, but here you go. Yeah. Like December all the way till next summer, I'm only working half time. So during that time, if you call me, it's a good chance, 50% yes, but I'll be doing nothing. Yeah, maybe.
You work in Hawaii, or you just live there?
No, I did volunteer stuff with the Maui Health Center, and they actually have an AED program there.
Yeah, actually my friend just did it last year.
Really?
He's in Texas.
Your friend? What's his name?
Blake Ishigawa.
Because I taught with Dr. Matsuda, the Japanese guy. I taught with him. He was the AACD president at one time.
Mm-hmm. And that's what the AED like?
Yeah, AED. Yeah.
Wow.
Okay, here we go. So this is kind of interesting. I mean, we were talking about should this be a full bony or not, right? I'm using a drill. I had to do a flap, so in my mind, yeah, this is definitely a full bony. When I do it in my periosteal, Did I put it down somewhere? Oh, there it is. There it is. So I'm just trying to get an idea of where the tooth is here. There we go. So I can see the buccal surface. Okay, so you can kind of... Sometimes, it's really easy to see right from the beginning and you just keep going with your coughing and everything, but when you can't see, then you do this, and then you know where the shape is and you know where to start the cough. It makes it easier. So if I have to stop to see better, to get oriented, I'll do that. So the rest of this should be really easy. Now that we know where everything is. So you can see it, Brent, right?
Sure can, yeah.
Okay, so here we go. So first the distal, and I'm going about 1/2 of the way to the lingual there. And then medial. Okay, good. Okay, let me try something here. I think we're gonna go ahead and section this one. Even though I could stop and try to elevate it out, but it'll probably be easier just to section. So this time I'm gonna come on the distal of it. Sorry, it's not going to be easy for everybody to see it. Okay. I'm trying to be really careful that I don't go too far on the window. Okay, you can see what we got there. This should be look really familiar, and it's repetitive. It's the same thing, you know, all the time. Okay, so now we're going to split, and you'll hear a popping sound now, right? So, hear that? That's the split part. Okay. My instrument's slipping a little bit. That's right. It's not popping out the other way. It's actually super loose, this distal half, but my instrument is slipping a little bit. There we go. Okay, so now you can just pick it out. Like Valentina's getting it for us. It's, you know, once it pops out, so we got the distal half, right?
Yep.
Now there's a lot of room there, right? Who was asking about Jack? I guess he's gone. He was asking, why don't you take out the mesial? Right?
Because there is no room now.
Yeah, I mean, there's this way now we can move the tooth to the distal
Right.
because there's a huge space there. And as soon as I get this guy moving, you'll see what I
Once
mean.
you start doing them, you realize you cannot take the mesial
Okay, so
out.
look now. So right, there's the mesial half. I mean, obviously it's basically out. If it's too big to fit out of fit out of the hole there, then I'll just section it again and take this out with cotton pliers. So it doesn't take much force. Oh, okay. Okay. So when I do my progress notes, I'm going to put Dr. Redden extracted that to Dr. Redden, yes.
Elevated without complications.
Yeah.
The assistants love that. People pick up a tooth.
Right.
They get so excited.
Oh, I know. They're going to go home at night and say, tell their husbands that, why I did an extraction today. I'm trying to get this out so we don't get the Sean Lee, the problem with the cyst developing.
Yeah, sometimes I had problems with getting that tissue too close. Like, it's too tight, and I put a hemostat and I kind of cut it around,
Yeah.
I didn't know how to wiggle it.
Having the right hemostats is kind of important too, because what happens is that in your office, like you got, especially if you're like a GP officer, you're a prosthodontic, right?
Right.
So your assistants are grabbing these, like you should have a surgical kit, and nobody touches that.
Right.
Because they try to remove temps with this,
Yeah.
and it bends the beaks, and then you can't grab anything with it. So, and they don't know the difference between a hemostat and an expensive needle holder too.
Right.
These are hemostats, but they
Right.
mine are kind of middle of the road, but my needle holders are about $165.
Right.
They have a carbide insert in it. They make that.
Has shorter jaws.
Yeah, my advice is make sure you have you got a surgical kit and
Right.
don't let the assistants use those instruments. I'm just trying to get a little bit more of the.
Well, it's funny, another time they
Okay,
set me
I guess
up
that's
and
it.
they gave me a short mustache.
Okay.
You're looking at reaching the last. So it's just learning curve, learning experience.
Absolutely, yep. So you know why we're switching, right? So you can get down inside the flap there. And also I can go way down inside the socket after I get the flap, like I'm on the outside here. After I get this really clean, then I want to have the small one so that I can get all way down in the socket that I'm going to check. And I want to make sure, sometimes, when I'm doing these, I'll actually see the nerve. Just see it, which is a good thing, that I can see it right there. I know it's there. That's really clean in my book. And so we're ready to go. I can just suture it up. And then we do the last one. And that's it. So can you, let's see here. Let me just see if we can
get a shot of it.
Yeah. Oh, it's really hard to see.
Yeah, it is.
It's okay. It's harder on the lower right, huh?
Yeah.
Lower left is a little bit easier. Okay, so again, look, see how the papilla is folded under there? So you can see the papilla. So you want to check that before you. Just just go in here and get it going back where it's supposed to go. So basically, you want to just check, make sure that it's there. It's in the right position before you suture. And that relaxes the flap too, so that everything's going back, and then you know where to put this because you want to get this in the right position. Otherwise, if you don't do it like that, you're not careful with it, you might have your flap be kind of loose, and then it won't heal as well. But look at this, like
No bleeding.
there's not much bleeding, but if you look at the way that the incision, I took out that distal wedge. That's why it looks like this. You can see how the edges are parallel, right, and it's pretty clean. So if you had that little piece of tissue, it doesn't know where to go. It's extra tissue, so it's going to kind of like pile up, and you end up with a pseudo pocket later on. Besides not closing very well, when you close, it's going to be all kind of crumply. There's going to be excess tissues. It's not going to be a nice straight line. So it looks a lot better, and it is better. It's going to heal better if it's like this. So I like doing the distal wedge on the lowers. So I don't think that Justin learned a lot today, but he learned about the distal wedge, so he got something. It's worth coming from Louisiana for that.
Is this brand good for the 15? The sharpness? Does it stay good for?
I don't really pay too much attention to that.
Yeah, because it's just a shortcut.
I'm not the right person to ask about that. I don't know.
Sometimes they just don't even get a good one.
Some of them are not good quality.
Incision,
Yeah. Well, honestly, sometimes this thing gets wound around the wrong way. I'll do it this way. Okay, that's good enough. We got it here. Okay, good. Oh, thanks. Okay. So this is really a good example of how, leaving it open a little bit to drain. I think you were the one that said that, Manira, right?
I usually put two sutures.
You can
see, one here,
you got one suture on the distal,
right.
And the whole back, there's a big space like this so it can drain. Resnick talks about that on that online oral surgery thing, but he does his sutures between the first and second molar. I just is the way that I learned how to do it from, and this is how I'm going to keep doing it. Yeah, I think that it's kind of a waste of time.
Right.
If you use good quality sutures and you're putting them in the right position, you don't have to do two. Okay. I mean, I haven't done two in a long time, and I'm fine with it. I never had any problems with anything coming loose. So far I don't. Unless there was you could do it on a selected basis, Brent. Like somebody really is squirrely. If you got a patient or a mom or something you think is particularly worried. Then I would be, I would say it might be a good idea, and I'll do it. But otherwise, I don't think they need it. I mean, I haven't done that ever. And I've done, thousands of these, and I've never had any problem. They're just most of the time they're surprised I even called the night of the surgery. And they usually are very thankful. Like, wow, it's really nice. Thank you very much, and you did a great job. And I hear that all the time.
Have you treated many controlled diabetics?
I don't know about many.
Or a few.
But yeah, I've definitely treated them, yeah.
I know I have one in the schedule for you.
Yeah. It's they're doing insulin every day.
Yeah.
So that should be, they should be the first patient of the day. So they can help control their diet. If they've got a diabetic.
I believe that's
we want to because
I recommended the pump site be changed the day before.
Yeah.
Get it fresh.
Okay. Yeah, I think, and that should be. I think that should be the first patient, and I would feel more comfortable on one like that if Tom was there. If we did it the same day that he's there. But it doesn't have to be that way. I'm just trying to get this wedge up a little bit. On patients that are kind of a little bit moving and a little bit, they make a few noises and whatever. Mm-hmm. Most of the time on those patients, if you keep going, they might even be crying. Mm-hmm. Usually by the time, I might add more on the IV, but usually by the time you get done, they're like this. They don't make a fuss anymore. Okay, so
I've had a couple patients want to kind of turn over on the side to get comfortable to sleep, and they just body they want to roll over or something.
Oh, really?
Side sleeping position.
Yeah. Wow. Huh. Steve, this is because I didn't get the 15 was kind of dull. I didn't get my incision all the way around the bone, so I'm going to try to open that a little bit more with these. Right there. Okay, that should do it. Be enough. I'm cheap, but if I wasn't so cheap, I'd probably just take out another 15 for each side, Okay, we're done with that. Okay, last one. Here we go. One more look. This looks really easy. Okay. There we go. Oh, can we see all right there? Actually, you can see pretty good on this one.
There we go. Keep them there.
Okay, water. Move the suction back a little bit. Okay.
Stop.
Okay.
Yeah.
Ready to go here?
Hold on. Give me a sec. Okay, go.
Hold the suction all the way down. Hold the
Put it on
suction.
the bone.
Okay, we're getting on my camera working underwater here.
Yeah, put it on the bone. Yeah.
Okay, there we go. Got it. I think that's it for the hand piece. If we had 2 or 3 more teeth to do, I would give them a little bit more ID now, but this is the last one, so. There's mostly pressure that I can do now. There's a little bit of lingual bone here. Can you take that out for a second? Yeah, I can't get my hand in the right position here. Right now it's just the tissue that's holding it in, actually. Okay, so that is down. Okay. This is frustrating when they're like this, because the tooth is basically out. Okay, let's do it this way. It's the lingual tissue, so I'm just going to move it back a little bit here. There we go. Okay. On this one, when I first moved it like that, that might have actually touched the nerve. We might be able to see the nerve on this because you're sort of acting like it's right on top of it.
I see.
Yeah. So he was doing that even when I was talking, so I think he's just, that looks good. Okay, we're done. Remember when I broke my arm and how I was screaming? You could hear it 3 blocks away. So the fact that they're making a little bit of noise, that doesn't mean that they're actually feeling pain. They're just responding to something, and they won't remember. So.
I didn't break down.
It's embarrassing, but I fell off a dumpster. Yeah, this is that serious. I was like, when I had my own office, we had a bunch of, it was raining outside. I took a big plastic bag of garbage out, and the dumpster was full, so there was a wall. It was a light rain, it was at night too, and there was it was a big dumpster. It was all filled with the bags, and I threw my bag on there, and it kept falling off, so I kind of, when it jumped over there, it kind of like stamped it down a little bit. I fell up in between the wall, and the dumpster was about 2 feet, and I kind of went down head first, so I couldn't do anything, and I put my arm out to break my fall. It was a big dumpster, so it was like 10 foot deal, and my wrist snapped, broke it in 4 places. And it was raining. It was like one of the stupidest things I've ever done. So, yeah, but I've done that. Done some crazy things in my life.
I broke both of my ankles.
Yeah? Ew,
In the last
ouch.
last quarter of the dental school.
Wow, look at that shot. That's good.
Really
Really good. Okay, I got this. So I'm just going to make sure everything looks good there.
See how they look. The phone
Yeah, I was kind of hoping that we would see a nerve here today, but we don't. We can't see it now. No, it's not. Even though on the X-ray it looks like it's there, you can't see it. You can't see it. Everything's really clean. Weird. I'm just going to put a suture in there. I'm going to clean up this little corner, that tag there. We'll cut that off. Let me get this.
2 months.
What I do with the scissors. Let's got the scissors. Okay. This is kind of ugly. Let's just get this little tag off of here.
3 months of physical therapy. And they gave me morphine from PR. And I remember when my husband was driving home,
That's it. Let's go.
cannot be giving me morphine because they're both broken. I couldn't take the steps, and then I realized that I didn't even know we had a bigger step. The last one was bigger than the other one.
Okay.
So,
And we'll take it out.
that time
No, that's okay. I think it helps with the camera.
Maybe you can get those photography retractors. I don't know, that would be...
Yeah, the thing is, it's hard to work. You know what I mean?
Yeah.
Even with what you've got now, it makes it a little bit more awkward than what I'm used to.
I got a lot of practice from actually he's skiing. He's a great skier. And 2 years ago, he twisted his arm. He was something on his ski. And he could not help it. So he had to be retired.
That's
It was
perfect.
the ligament. It showed that my country to recover when he was 55. So, I was at 20 when it happened. So, the recovery is different.
Beautiful. So the usual. I'm just gonna hold everything and then check it.
And he didn't have any disability.
Yeah, that's all it takes.
So he did not.
You can see
So
that everything looks like it's in pretty good position there.
there.